Challenge.
Thank you so much, Dr. Aaron, and thanks AIOS and VRSI for asking me to be a part of this wonderful symposium. So, yeah. So, are my slides visible?
Yes, Mudit.
So, I'll go on. So, I'll be talking for some time on vitreoretinal surgeries and eyes with keratoprosthesis. Now, keratoprosthesis can usually be a boon to a lot of patients, including patients with Steven Johnson's, corneal scarring, resolved endophthalmitis. So in these eyes where earlier we were resorting to no options or just leaving them behind, now in poor ocular surface cases, keratoprosthesis have kind of revolutionized their visual acuity and their improvements. But the problem is that they come with their own set of complications. And before we go on to them and the problems which we can face, it's important to understand the types of KPros which are available, because that will also determine how we approach them surgically. So the two common types of KPros are either the Boston keratoprosthesis type 1 or also the one which is made by Orolab, the Oro KPro type 1, which has got a corneal button and they've got the plate and this optical central cylinder, or a modification of which has been done in LVPI, the LVPI KPro, and I'll come to how it looks like, or the type 2 KPro. Now, while the type 1 KPro had a corneal button and the rest of the sclera and the adnexa was clear, type 2 KPros are the ones which are done in eyes which have got a very poor ocular surface and dry eyes, severe dry eyes, where they do a complete tarsorrhaphy and then beyond that they go on to make an incision and introduce the KPro. Or the LVPI KPro, where you've got this mucosa over here. And the problem that comes in these eyes is, regarding most importantly, is the area where you make your sclerotomy or the entry into these chambers and the subsequent visualization. So what are the common indications of why do we need to do a VR surgery in most of these cases? The most common indication usually is the presence of a retroprosthetic membrane, like what you see over here. Apart from that, vitritis, retinal detachments, hemorrhages, all other retinal pathologies can be an indication, and we need to approach them. And these eyes are amenable to good outcomes with a vitreoretinal surgery. So like I said, retroprosthetic membranes, endophthalmitis, detachments, and hemorrhages are the common indications for a VR surgery in these cases. Now, if you look at this over here, now for a Boston KPro type 1, making the sclerotomies is not difficult. You can easily make the sclerotomies just the way you conventionally make in your other VR surgeries. And this shows over here, this was one of our patients. Most of the periphery is also visualized. You can easily visualize the break and do the steps of your detachment surgery or your VR surgery. The important points to keep in mind are your entries and the visualization. So the problem comes in KPro eyes, the type 2 KPros. I'll just. And this is what you can do in these eyes. You can subsequently go ahead and you can measure from the center of the optical cylinder. And once you have measured from the center of the optical cylinder, you can go in. This was one patient where we ended up doing the endoscopic surgery. And the most important step is to visualize your cannula so as to ensure that you do not have a subretinal, subchoroidal, or subciliary placement of your cannula. The other challenge is these retroprosthetic membranes. And again, they are easily amenable to surgery. And you can use either a 25 gauge cutter or a 23 gauge cutter to easily dissect it. And you can do a vitrectomy and remove these membranes. And once you remove the retroprosthetic membrane, the view becomes clearer. The surgery becomes easy. Alternately, what you can also do is you can take a 25 gauge scissor inside the eye and truncate the membrane like a petaloid in a petaloid manner. And once you have created 4 or 5 septa, you can again use your cutter. We did not have to resort to that because in this case, just with the help of a cutter, we were able to get a clear visual axis and clear all of these membranes. And that allowed us to subsequently proceed with the surgery. This patient had vitritis and vitreous hemorrhage. And once we had removed the retroprosthetic membrane, the rest of the steps of the surgery became significantly easy. So like I was saying, vitrectomy in detachments again can be something which can be easily done. The main concern which we have in these cases is that will we have an adequate visualization? And the visualization usually is not a difficulty, like what you can see in this video. Not only were we able to do a surgery, you can easily go inside, do a vitrectomy, but all the other steps of a conventional VR surgery, including inducing a PVD or removing the peripheral vitreous, all of those steps can be easily visualized. So we need to get beyond this thought that an optical cylinder of a KPro will occlude a visualization. We can still go inside and do all the steps. The only caveat subsequently comes in the post-operative care of these patients, because IOP assessment can be difficult. These eyes are anyway subject to or predisposed to glaucoma. So some of these eyes may need an early siliconal removal. In fact, this patient came to us with a visual acuity of 20 by 400. We ended up doing a surgery. This patient also had an MF glaucoma valve, incidentally. And so because we did not want the valve to get occluded by emulsified oil, we ended up removing the silicone oil just after 1 month. And this patient ended up doing well. So most of the steps, like I said, can be done here. You can visualize the periphery and a cryo being done and peripheral laser being easily done. So this is another case where we ended up doing a surgery utilizing an endoscopic setup. So endoscopy also comes to our rescue in cases where we might not be able to visualize things properly.
And removed.
So with the help of an endoscope, we can easily visualize the periphery, gain access to these sites, which could probably not have been amenable to a conventional visualization. And here you can go ahead, remove the peripheral vitreous entirely in toto. And in this case, we ended up using PFCL to flatten the retina.
PFCL was used to flatten the retina, and the fluid was drained from the peripheral breaks. The peripheral breaks were lasered, and the surgery was completed after injecting silicone oil.
So I think in the interest of time, I will not go and show the rest of the steps. The rest of the steps are similar to what we do for a conventional surgery. So the point over here is that VR surgery in eyes with KPros have only 2 important points for us to be cognizant of. And if we take care of them, the rest of the surgery is not that difficult. The most important point is your port construction and to visualize your entry site and to ensure that your cannula is placed properly. And the second point is a proper adequate visualization. So taking care of the retroprosthetic membrane, ensuring that you're in a proper plane will take care of the visualization, and subsequently the rest of the surgery can be accomplished just like the way we do our conventional VR surgeries. Thank you.
Thanks, Mudit. Excellent videos. And I think